Hello, my name is Annette Sikorsky. I'm currently a clinic charge nurse at the UVA Cancer Center in Fishersville. Previous to that, I was an infusion nurse at the same location. And previous to that, I was an inpatient oncology nurse. So I've spent most of my career dealing with oncology patients and understanding their disease processes and the treatments that we use to help them. Um, so, given my previous experience as an infusion nurse, I have been able to understand the needs for communication between both providers, nursing, and communication between our different levels of staff that we have on site. We have CMAs, LPNs, and RNs, along with nurse care coordinators and several other administrative roles. Um, and so for my topic change, um, project, I picked implementing effective interprofessional communication in the ambulatory oncology clinic and infusion center settings. So, the problem in current state, we have gaps in communication between clinic and infusion staff, and that is both nurse to nurse as well as nursing to providers. And the potential impacts of this are that it can cause delays in patient care, miscommunication, which leads to staff frustration and patient safety risks. Um, so the goal of this change is to create a well-oiled machine in our setting as it is, by improving our collaboration, clarifying our roles and responsibilities, and establishing reliable communication pathways. When it comes to strategies for change, our first and foremost strategy for change is to define clearly the roles and responsibilities that each person has. And so, due to us having multiple um, layers of staff, be it a CMA, an LPN, or an RN, understanding the scope of practice for each of these and understanding whether or not who you're trying to communicate with is the right person for what you're trying to communicate. And also making sure that what you're asking of someone is within their scope of practice. This is especially true when it comes to LPNs and RNs, because we have a similar scope but not quite the same. And so understanding um, that expectation can help, and also understanding everybody's role in the clinic. For example, nurse care coordinators, they do not have as much of a clinical hands-on patient care role. They have more of an administrative side of things. That's where their tasks lie, as well as triaging in-basket messages and patient education, with our oncology patients, especially our new start patients. Um, our second strategy for change is to implement Vocera badges in the paging system. Vocera badges in the clinic would be exceptionally helpful, especially when we are spread out among several different exam rooms. And for me as a charge nurse, if my staff need me for a hard stick, if they need me to bring them additional supplies, or if they're in a room with a closed door and they're having a patient who is suddenly feeling very ill, feels like they're going to pass out, things like that, Vocera badges would be exceptionally helpful, as it provides a direct line of communication at all times. And the Vocera paging system is something that is already in use when it comes to paging providers that are not on site, as we see several patients that have their main provider in Charlottesville. Um, so, implementing that same paging system, even for providers that are on site, would be exceptionally helpful, as it would limit the amount of interruptions uh, during a clinic. Our providers are very busy. They can see anywhere from 15 to 22, 23 patients a day. So any interruption that can be minimized would be exceptionally helpful in their realm. Um, our third strategy for change is to strengthen the relationship between clinic and infusion. We are two arms on the same body, and understanding that our cooperation is essential for handing off patients from one side to another safely and efficiently, and that our patients pick up on the relationship and the interactions that we have with one another, even if they're subtle, nonverbal interactions, ensuring that we're working as best as we can together is exceptionally important. Our fourth strategy for change would be structured escalation pathways. So, understanding the difference between something that is non urgent, that can be sent to the clinical pool in an Epic in basket message. That way, that it can be triaged in a timely fashion by our nurses that take care of that, versus something that is a little bit more important that you might need to interrupt a provider in clinic for, especially when it comes to treatment parameters, a change in patient condition that might affect whether or not they receive their treatment or the way that they receive their treatment, versus our emergent scenarios where we pull our emergency cord and a provider must report on site at the chair side in infusion. So I think that having those structured escalation pathways and the use of Vocera, the paging system as well, can really be helpful to strengthening our communication. And our last strategy for change is the consistent use of our status board within Epic. Our status board often is a reflection of a real-time state of patient flow. So ensuring that the status board is as up to date as possible helps keep patients flowing in and out of the clinic and in and out of the infusion centers in a timely manner. It also can tell us if a patient has been sitting in a room for longer than they should be, and whether or not we need to address something additional before the patient is either discharged or sent over to the infusion center. Our timeline for implementation. So in the first month, we can just assess our challenges at hand, educate staff on what is to come, and train staff on proper usage of the status board. That way that implementation will be a little bit smoother. In months 2 and 3, rolling out the Vocera badges and providing proper training on that. Holding joint staff meetings to help strengthen the relationship between infusion and clinic, as well as allowing for open feedback from staff. Months 4 to 5, we can really work to formalize our escalation pathways, talking about that non-urgent versus urgent or emergent scenarios, and really making sure that staff understand what constitutes for each of those scenarios is very important. And then conducting staff surveys and collecting data on clinic interruptions from a provider or nurse care coordinator standpoint are all things that are helpful when it comes to implementation. And then the last piece of our timeline is the 6th month. We can evaluate our results, compare it to our baseline when we started, and then adjust as needed from there. When it comes to areas of support and resistance, so areas of support, a big one would be, a big proponent for this is definitely from the provider standpoint. They would benefit the most from fewer unnecessary interruptions and more structured communication. Our infusion nurses are also going to be, they'll likely welcome faster assistance in urgent situations, because providers will count on that when they need something, it's truly an urgent or emergent need, and respond quickly. So from a leadership perspective as a charge nurse, and the infusion charge nurses, supporting smoother operations and patient safety is a huge benefit of increasing our communication across the board. And our patients also are like an indirect supporter of this, and that can be shown through patient satisfaction scores and as well as the perceived improvement of care. Um, Areas of resistance. The biggest one is that some staff might be resistant to newer technologies such as the Vocera badges or the Vocera paging system. Um, longer, oh my gosh, staff that have been here longer might prefer older ways of communication, as in just walking over to the provider's offices or pulling them from a clinic room to ask them a question in the moment. I think skepticism about whether these structured escalation pathways are going to work is a huge point of that could be end up being a point of resistance, um, because people are creatures of habit and they do not want to break said habits. Expected outcomes from this: safer, more efficient patient care is the bottom line and the most important factor of improving our communication and collaboration. A stronger sense of teamwork and job satisfaction across the board, um, higher patient satisfaction scores and Press Ganey scores, as I've said before, and then just being better prepared for our ever rising patient volumes. Um, so all that to say that communication is a foundation of safe and efficient care in an ambulatory oncology setting. Um, and so by committing to structured communication today, we can guarantee safer and more efficient care in the future.